rather than volunteering from each one of you to be in the front line once the crisis will be extended or increasing more than that. I am Ahmed Madi, ICU consultant and director of the course, as well as director of the fellowship and the residency program in critical care department in the Kingswood Medical City. I'd like to thank you all again, and actually, I just want to say thank all the people behind this work. I have actually the organizing committee, the co-director, Dr. Ahmed Kohel. He's the one always handling all technical and zooming and admitting the people and everything related to the online technology, as well as Dr. Abul Takin. She's a chief consultant in ICU, and she's also handling the scientific material, the content of the program, as well as she's sending you all of the material related to the course, and she's arranging the MCQ at the end of the course. I have actually two coordinators. They are working hardly behind every administrative part, which is Christina and Emiliana. I'd like to thanks them actually. I have a faculty, 12 speakers actually behind this work. Almost I will thank all of them during the program, which I will show you soon. Okay, good. So I think everything is going well now. Just kindly keep your mic mute. In case you need something, you can just raise your hand or write in the chat room, and we will admit what you are doing. I can see many specialty here actually in the course. This course actually is designed for the cluster for non-ICU physicians to just prepare for the, let us say, essentials of critical care that they can handle during the crisis. And I'd like actually to make you not panic, because almost you will have supervised by the ICU specialist as well as ICU consultant. The online critical care course for non-ICU physicians, actually, it is one of the the surge plan of the cluster, which is done by the leaders. And Dr. Rahman Al-Harthi is handling the critical care line service in the cluster. And the idea is they are dividing the crisis into 5 phases, right? The phase 5, which we are going now. Right? Phase 5 is the least one. They are counting, for example, the bed number in all the clusters, isolation number, or critical care patient number in all the clusters. Let us say once reached a certain number, which is almost 160, they can jump to this phase 4, and from phase 4 to phase 3, and the highest, which is phase 1, I hope we will not reach it, which is almost will be the most crowded, and they are planning for the 400 critical ill patient beds in all the clusters. So we are preparing for the phase 4 from now and phase 3. So if we go through the surge plan for the staffing, we have a model of 25 beds. So we are increasing the number by 25 beds. So if we have 25 beds open, ICU new in any hospital of the crisis of the cluster, what we need actually, we need for each 12 hours, 1 ICU consultants, 2 ICU specialists, and we need 4 critical care RT and 4 non-ICU physicians. Those ICU physicians will handling actually 1 to 6 patients with specialists for ELV12, with consultant for each 25, as well as the nurses also. So this is a model for the crisis, for the surge management, for the all, as a general, let us say a unit of the surge plan, right? A model of the surge plan. So based on that, we are trained many non-ICU physicians to be with us in the front line. And assignment actually will be done by the rota supervisor over the cluster, as well as the leadership. of course. So just we need you to know something about the ICU, how to deal with the ICU patients in case we will have the need for this, right? So we will not go in deep for the ICU topics, but we will touch most of the most common topics you are need to know about the ICU as well as the COVID-19. COVID-19. So if we go in our course, we have actually online online lectures, which will be all over 4 days. These online lectures with interactive quiz. It means in every lecture you will find one or two MCQs or three MCQ questions, and you need to answer during or vote during the lecture. Right? It is not difficult actually. It is related to the topic and it's very simple and very easy. Then we select online courses, free online course from the societies. One of them from the Critical Care Society, American Critical Care Society. This is the biggest society of the intensive care worldwide. And the other one is from Muhammad bin Rashid University. And we have some videos already posted by Dr. Gultakin, and we sent all of these links, I think, yesterday, just to review and to check during your the 4 days, of course, the course of the 4 days. By the end, we will have last day after we finish the course, you will have like 40 MCQ questions. Most, I can say 90% of the questions will be from the lecture itself. The balls we are discussing during the lecture, it will be in your MCQ at the end. If we have a plan for people to join us and because of the infection control restrictions, we'll try to do like small group teachings for hands-on and procedures like intubation, like airway management, like vascular access, or like PPE equipments. This is in case we'll schedule people to join us, a doctor from you. So we'll try 1 day or 2 days earlier of the joining to have like workshops, hands-on on models, as well as we are trying to make like small pocket hands-out, small guide with most of the algorithms and the what you need during ICU, like mechanical ventilation, like ARDS, some hints to be just in your pocket in case you need them. Right? So this is the outline. The first course actually is related to the infection control, which is Muhammad bin Rashid University course. It is 1 hour only course. I think it is already distributed now in the cluster, which is recommended to go through. It is 1 hour. It is related to the infection control, prevention and control of spread of COVID-19. The course covers the chain of the infection disease and the transmitted, and how to break the chain of infection through concrete preventive actions. We recommend to go through this link and have this certificate. And I think there is some of you, they posted the certificate, they posted the certificate yesterday of the discourse. I cannot hear. The voice and the videos are lagging. How can it fix it? Just it is individual from Dr. Wujdan and Dr. Nabila, or all of you. Just if the voice is clear and the slides is clear, just post in the chat. I just want 3 or 4 to post in the chat. Is it okay, or you have problem with the voice? Clear. Great. Okay, so we'll continue. Thank you so much. So I think the doctor, you can check your audio and your video system. Thank you. So this is the first course. The free online course. We retrieve the link and we advise everyone to go through. The other course is Society of Critical Care Medicine in the USA. They did a free course for non-intensivists. This free course contains modules from the 2 essential courses they are doing. One of them is fundamental of the critical care, and one of them is crisis management. We select actually 6 modules from both of them, which is we feel those are relevant to our society and our community. We need you to go through of them, like airway, like basic mechanical ventilation, like shock. Those we are select those 6 modules. So you can go through those 6 modules, and you can find lectures with interactive and actually some of the questions in between. Keep in your mind, we retrieve some questions from those lectures, and it will be in the MSQ at the end. So the MSQ at the end will be a combination of the polls and the lecture inside during the online lecture and from the online free courses you have to go through. And now I will go through the first poll. If you have time to vote, did you go through the material sent yesterday and day before yesterday? Only yesterday and today. Just did you go through it or not? You can just vote yes or no. Okay, 10 seconds more and I will stop voting. I can feel still 15 away from the devices. Not 15, almost 20 away from the devices. Maybe they wrote in the chat. Good, okay, yes. So I can find here now, I can stop polling. So almost half of you went through the materials and half didn't go. Still you have the time in the upcoming 4 days to go through the material to see what's going on. I will go now to the our program. We have 4 days program. First day today will start at 8. Now we start with the course introduction. Each lecture almost it will be 30 minutes. After that, Dr. Shahzad will go through the pathway definitions, triaging of the COVID-19 patient, one of our ICU consultants, followed by Dr. Tasmia, she's the infection control coordinator in ICU. She will talk about PPE donning and doffing, infection control measurements for COVID-19, and I will be at the last lecture. I will talk about the just a quick guide of the pathophysiology stages, management of critical air patient with COVID-19. Tomorrow we'll start at 8 p.m. Also, we'll start with shock and fluid management with Dr. Ahmed Kouhail, CPR dynamics in COVID-19, Dr. Saima Shahzad, and our ISO consultants, Dr. Basim Hawid, he will go through basics of mechanical ventilation. Dr. Omar Ramadan, he will go the ARDS in COVID-19 patients, heavy topics to be discussed. There is one lecture I will arrange for this lecture mostly tomorrow or after tomorrow. It will be the pathophysiology of the COVID-19 patients. You have to know because there is many pathophysiology which is actually has to be reflected on the management of the ARDS and even in pharmacotherapy. It will be done by Dr. Waqqas. I will incorporate in the program. The Monday, this Sunday, Monday, we will have 1 day break in between, which is Tuesday. In the Tuesday, we have a webinar by 2 consultants, one from our consultant, Dr. Salman Abdelaziz, will present diagnostic imaging for COVID-19. This is optional. This webinar will be on Tuesday from 8 to 10. It is optional also. If you like to attend, you're welcome. And Dr. Muhammad Shif, this is a consultant of the vascular medicine and the thrombosis, because actually new era of thrombosis now for the COVID-19. He will talk about thrombosis challenges for COVID-19. So we will post the link of this webinar separately from the link of the course. And we will continue our course from Wednesday. Wednesday we'll have pharmacology of COVID-19, Dr. Bashir Abdurrahman. I would like to thank him as a clinical pharmacist in ICU. He will talk about the most essential approved drugs by Ministry of Health and our protocol of the cluster for treating COVID-19. We'll follow that with some hint about sedation and analgesia for time. Dr. Muhammad Al-Udati will present acute kidney injury COVID-19, followed by Dr. Ahmed Al-Balshi, our ICU consultant, to talk about pneumonia. Last day, Thursday, we'll have Dr. Abul Takin. She will present EBG interpretation, as well as Dr. Walid Tharwat will present airway management and many videos inside his, because we cannot do currently hands-on, so he's trying to do simulation videos for COVID-19. We will end with MCQ 40 questions, as I told you, to be involved from the all the lectures we have. By the Thursday, end of the MCQ, it will be length for 1 hour or less almost, and we will finish our course and certificate programs. So I have a last question for all of you. Scale your expected need satisfaction from course contents. Just expect it. Did you expect it will add nothing for you, or it will give you a fair or excellent need to satisfy your need? I think we have poll. You can vote. Yes, we can start voting from 1 to 5. 1 is nil, 5 to max. I will wait for 10 seconds more. I hope all the participants they will share. None. Okay. So by this, most of you, I hope we can just meet your expectation at the end of the course. We posted pre-survey, and at the end of the course, we will post a post-course survey, right, including also your assessment and your feedback. So kindly, and we are taking attendance during your course. Zooming, we are taking the attendance. So the assessment all over the course will be included the pre-course survey, the interaction during the course with polls, and the attendance in every lectures with the Zooming attendance. So kindly, once you will join the Zoom, write your name clearly, because this name will shown to us during attendance and at the end with the certificates. And we will finish with the MCQ by the end of the course, and certificates will be released at the end, beginning of the next week. I'd like to thank you for your presence again and for with us in the COVID, and I hope you will get some benefit from these materials by the end. Do you have any queries, any questions before we'll go to the first speaker? Yes, Wise, I agree with you. Polls. If you don't have the chance for polls, you can write here. So, thank you so much. I will go now. I will present now one from our very active consultants in our ICU, and Dr. If I may ask, when we will start actually working in the ICU? Very good questions from Hattan. I told you this is based on the phases of the surge plan. We're still in the phase 5, which is the least phase. We agree with the leadership of the cluster. Once we reach the phases, it is divided by the number of patients, confirmed and suspected patients in all the clusters. I will give you example. The phase 5, the least phase. Now, we can accommodate 150 COVID-19 patients in all clusters. So if we did reach to 75% of this phase, which is 100 plus 25 maybe, for example, we will start to prepare the staffing for the phase 4. Phase 4, the capacity is supposed to be 250, for example. I'm not disclosing the numbers. So once we reach 75 of this phase, we will prepare for the next phase, which is phase 3. Phase 3, we have 280. So in phase 3, 2, and 1, we need you and ICU support. In phase 5 and 4, ICU can do the job. So once we will start simply roughly to reach 280 patients in the cluster of COVID, suspected and confirmed cases, we will need your support. If you did ask me what is the expected time, nobody knows, but actually the statistics said in the Ministry of Health, the peak can be May 10 or May 9. This is the highest peak of the COVID-19 expectation for the Riyadh region. So in this, if we just pass this state, so almost will be safe. The curve will go down, inshallah, right? So when we need you, when we reach 280 cases in the cluster, at that time or earlier, few days earlier, we will distribute you for the isolation beds in the clusters. I hope I did answer your question. Who should we send our clear names to? At beginning, in the registration of the conference of the course, when there is a question, your screen. Okay, this is Ahmed Kohel, he replied.
Everything is okay?
They moved on the screen. Thank you so much. I will just now introduce Dr. Shahzad. Welcome, Dr. Shahzad. We will talk about the definition, pathway, triaging of the COVID-19 patient. Welcome, boss. You
Thank
can
you,
start
Dr.
sharing.
Mahdi.
I will stop sharing.
Yeah, sure. Dr. Mahdi, my voice is coming?
Yes, just a while.
Okay.
Excuse me. It's okay, I can hear you, boss.
Okay, screen, I will share now. It started to display my screen.
Still the question, but we didn't see your screen. Can you share it with us, please?
Okay, I'm sharing at this moment.
Your voice is not loudly. You can just make it more loud, please.
Sure, Dr. Mahdi. Now, Ahmad, is my screen is coming now?
Still not yet, doctor.
So I will go to the.
Not yet, boss.
Okay, boss. Okay, boss. It is failing.
Dr. Shahzad, can you share the screen or I can share it from my side? Dr. Shahzad?
Now screen is okay. Just your voice. We need your voice to show up.
Dr. Shahzad?
Yes, you can re-share again, please.
Yes.
Okay, good.
Dr. Mahdi, is it okay now?
It's okay now, but if you never mind, you can make your voice more loud. Thank you. Yes, Dr. Shahzad.
Yeah, sure. Sure,
Great,
Dr.
you can start.
Assalamu alaikum wa rahmatullah. Thank you, Dr. Mahdi, and thank you, Dr. Ahmed Kohel, and sorry for the disturbance in this connection. My name is Dr. Shahzad. welcome to the all participants in
Shahzad, your voice, excuse me, your voice is very slow and interrupted.
Virus. Though now it's okay.
Yes, this is the best one. Continue.
I think the voice was slightly volume was low.
Now it's good. Okay, and streaming very well. You can continue, please.
That's so case definition, and then we will discuss some pathways. My objective that at the end of the session, you will be able to have a clear introduction about the coronavirus. You can enumerate the causes of coronavirus and can count the signs and symptoms of COVID-19. You will be able to define what is the case definition of COVID-19 inside the kingdom and outside in the world, and pathways for admission from emergency department to the respective departments. As an introduction of the COVID-19 or coronavirus, it constitutes a family which named Coronaviridae and having a subfamily Orthocoronavirini. As an introduction, as Dr. Madi also said that there will be a question at the end of the session. So probably my lecture will have a 4 or 5 MCQs as well. So where the emphasis is more, think that something is there for the clue of a multiple choice question as well, questions as well. So coronaviruses are actually enveloped viruses. We know there are 2 kinds of viruses, enveloped or non-enveloped viruses. Coronavirus is an enveloped virus with a positive sense single-stranded RNA genome. Why we call it corona? Corona is a Latin word. It came from crown or halo. When we see this virus under the electron microscope, it has a surface which is covering in club-shaped protein spikes are coming out. So it's named as coronavirus. Is this pandemic or epidemic is new? The answer is no. The pandemic or epidemic has been started with different viruses since 2003. While if we go back the history, it is since decades and centuries have a virus involvement causing the pandemics. But we go with the specifically with the coronavirus. There was in 2003, severe acute respiratory syndrome, SARS outbreak was there in 2003. It involved Saudi Arabia and some of the countries in the world as well. Then 2012, we were facing the MERS coronavirus in Saudi Arabia and some other Arab countries as well. In 2015, resembling the MERS coronavirus, there was an outbreak in South Korea as well. And 2018, again hitting the multiple countries of the world. And now in 2019 and 20, it is another coronavirus which is affecting the world, which started from December 2019 as an pneumonia outbreak in the Wuhan city of China. By the end of the December 2019, we were able to define by the definition of WHO that it has almost the same genetic similarity to the SARS coronavirus, which appeared in 2003. Later on, they named as interim name was novel coronavirus 2019. We are doing today the 3rd course for the non-ICU physicians. This coronavirus is a deadly virus. What are the statistics of this virus about the involving the human beings, how it is getting transmitting? So if you see the chart above, the 5th April, I was presenting the data that the total cases today is 1 million and mortality around 50,000 people have been died. When I was doing the 2nd course on Sunday, 12th April, the total cases was 1.5 million and 100,000 people were died. Today is the 19th April, and as a world globally data is saying that total cases have been involved 2.3 million and 161,000 deaths are there. Wuhan strain was defined as a new strain of beta coronavirus. As we know, there are 4 groups of coronaviruses: alpha, beta, gamma, and delta. And then beta has 2 subtypes. So it is from the group 2B, with approximately having the genetic similarity to the SARS coronavirus, which was the epidemic in 2003. The virus has 96 similarity to the bat coronavirus. Most of the times we have this thought process that it has a zoonotic origin. It is caused by SARS-CoV-2 and same resemblance as I told you that the SARS-CoV-2 2003 epidemic, almost the same. it is a beta coronavirus like MERS corona and SARS-CoV, but much closer to the SARS. How it transfer? Is it animal to human? And it is human to human. There is a studies that zoonotic in origin is there, but from human to human, it has a transferred mode of transmissions are from respiratory droplets that the people exhale. There is a transmission of these viruses. These viruses can stay in the air. Initially, it was thought that it is only respiratory droplet. It does not cause any airborne transmission, but it does cause it, especially in the healthcare workers. The new studies are evolving that it causes the fecal-oral transmission as well. There are multiple patients have been found when the patient have been having a transmission from the fecal-oral route. Incubation period of this virus. What do we mean this incubation period? That if any person get affected with coronavirus, when the symptoms started to appear, this is the duration we call it incubation period. It usually from 1 to 14 days, but have been seen the 5th day is the mostly day when we have contracting the symptoms of this coronavirus. Although some cases have been seen that incubation period can be extended up to 27 days. What are the signs and symptoms of coronavirus? There are some specific and most of the time non-specific symptoms are there. Patient can be symptomatic, patient can be non-symptomatic, and atypical symptoms can be presented. As I discussed in the previous slide, patient can come with the GI route and having a GI manifestations like nausea, vomiting, diarrhea. Though it's a uncommon manifestations, but still patient has atypical symptoms affecting in some atypical clinical patients as well. So if we see the primary symptoms, it goes with fever, having a runny nose, dry cough, shortness of breath, body aches and fatigue. Fever has been recorded up to 38 degrees centigrade or 100 degree Fahrenheit. If we see this table, the fever is the most common symptom, which is 88% people are contracting the fever with the involvement of coronavirus. Dry cough is also have been discussed, and it is one of the clinical criteria also of the case definition, which is affecting the 67.7% people having a signs and symptoms of coronavirus. There are other symptoms are there, but it is very low percentage. But if we are seeing all the data in this table, if we see the nausea and vomiting, it is uncommon, but it is still affecting 5% of the total population with these signs and symptoms are appearing. Conjunctival congestion, though it is reported with 0.8%, but there are few reported cases are there where the patient presented only with the complaint of conjunctivitis. So that's why as a clinician, we have to think and see what are the typical presentations and what are the atypical presentations are there. Let's see the case definition of COVID-19, how we are defining. This is the latest updated guideline from the Ministry of Health, Saudi Arabia, which was updated on 2nd April of this month. So till now, this definition we are following all over the kingdom. So interim guide to define this case definition, that how we can suspect a case of COVID-19. Please be with me on this slide. If we understand this slide, I think the next, all the pathways we will be enumerating this table. So it is two sides of the slide is there. One is the white colored, which is a clinical presentation, and left one is the epidemiological link. So clinical presentation is patient is presented with acute respiratory illness. Now, with acute respiratory illness, he has at least one of the following symptoms. If he has fever, either it is mild or by history. Either he has cough or shortness of breath. Cough is here, dry cough. And in the 14 days prior to symptom onset, he met at least one of the following epidemiological criteria. So clinical presentation is that patient is presenting with acute respiratory illness with symptoms of fever, cough, shortness of breath. And in the 14 days prior to symptom onset, he has any one epidemiological criteria. What is the epidemiological criteria? For example, we are the one, we the physicians Working in healthcare facility, this is epidemiological link. So if working in healthcare facility where the corona patients are coming suspected or confirmed, we are examining, and then we have any one of the symptoms, that is a suspected COVID-19 definition. Had any history of travel abroad, that before the 12th March, after the 12th March, mostly the flights or travel restrictions are there, but before it was one of the epidemiological link. The persons coming from the countries where the high ratio of the patients are there, or have visited or being a resident of high risk area for COVID-19 in the kingdom. Most of you are getting the results, daily results of coronaviruses. Makkah, this cases, Medina, this cases. So where the most high yield of cases are coming, these are high risk area for COVID-19. So Makkah, Medina, Jeddah, Riyadh, Dammam, these are, or Qatif was initially, when this corona was started, was the areas being involved and labeled as high risk areas. Or epidemiological link, that close physical contact prior to symptom onset with the confirmed COVID-19 case. Now, this is the clinical presentation and having any one of the epidemiological link. The second clinical presentation does not need any epidemiological link. What is the second presentation is any admitted adult patient with unexplained severe acute respiratory illness. Either it has a community acquired pneumonia or hospital acquired pneumonia, but it is unexplained severe acute respiratory illness, goes to the definition to suspect that it is a suspected case of coronavirus. What is the definition of confirmed COVID-19? Confirmed COVID-19 case is defined the person whose PCR is positive for COVID-19 taken by the nasopharyngeal swab is a confirmed COVID-19 case. The last slide where epidemiological link was there was one word which says close contact. What we mean by the close contact? So close contact, healthcare associated exposure, including providing direct care for COVID-19 patients. You are the person living with the person in the same class, in the same room as a roommate or classmate in the class who has a positive COVID-19 history, traveling together with COVID-19 patient in any kind of transportation, and living in the same household as a COVID-19 patient is defined as close contact. Clinicians must observe the atypical presentations. Atypical presentation is mostly common in those patients where the patient have immunocompromised state, like chronic heart failure, post-renal transplant, post-transplant patients are there. These patients can come with the atypical presentation. Let's see after learning about the case definition, we are screening the patients in respiratory triage. Respiratory triage checklist in emergency department, and any patient coming to us, we have to triage that patient. Either he has to go towards the COVID-19 area, pulmo or respiratory clinic, or non-pulmo respiratory clinic. Very clear has been written, it has the number scheme. By the way, if you don't remember, this is the part of the file in MOH files. Take a paper of respiratory triage checklist and try to take a history to get any epidemiological link. If any epidemiological link is obtained, it scores 3. And then the clinical presentation, either fever, shortness of breath, cough, or gastrointestinal manifestation. 3 typical presentations in adult will score 2 each and pediatric 1 each. While nausea, vomiting, diarrhea has been observed in adults and it scores 1. If your score is more than 4, before 2nd April 2020, the score was 6. So the less people were coming in the screening. But the 2nd April, we have changed from the Ministry of Health, more than score 4, suspect, and especially with the epidemiological link, you have to ask the patient to perform hand hygiene, wear the surgical mask, though he has already wear in the new circumstances, the patients are coming in the respiratory clinics or triage clinic with the mask. If not, ask him to wear the mask and direct the patient for the medical doctor assessment in the respiratory clinic. Let's see the pathway. This pathway is very important for those especially those our non-ICU physicians are going to join either the emergency department or ICU of the cluster program. So suspected COVID-19 visual triage, if met the case definition, if no, will follow the regular triage system. If he has met the case definition, then it will be observed for the scoring, stabilization, and assessment, and whether patient needs any immediate life-saving procedure, for example, intubation, airway protection. If yes, he will go to the observation critical care bed. Bed management will be informed, procedure will be done, and it will be immediately evacuated to the critical care department. If he doesn't need any immediate life-saving procedure, we'll go to pulmo respiratory clinic, and there the patient will be assessed. If he is stable, fit for home isolation, just take the swab, notify MOH, and he will go for home isolation for 14 days. What is the criteria for home isolation? If his respiratory rate is less than 20, he don't have any dyspnea or shortness of breath, his chest X-ray is clear, and he's maintaining saturation more than 92% on room air, he is stable enough to go home for isolation. If he's not fit for home, inform the bed management and go for the direct admission. Now we'll see the admission pathway, that if the patient came, so we discussed in the last slide that patient was stable to home isolation or will go for the admission because he's unstable. Now, if he is unstable, as we mentioned, that meeting the case definition, going into the area where he will be observed for the intubation or high frequency nasal cannula, for example, or high oxygen supply, here will be assessed with the critical care physicians. He will be stabilized and will try to evacuate him as early as possible towards the ICU COVID-19 beds or COVID-19 area. The time of evacuation from emergency department to ICU is 15 minutes. If this patient is not admitted in the ER, the medical specialist or medical on-call will accompany the patient to ICU, and he will begin the admission process. If not done in the ER, he will do it all the things in ICU. In ICU or in the living area, we'll collect 2 nasopharyngeal swabs, depending upon the ICU consultant discretion. They will send the sample for COVID-19 and the second for MERS, Corona, and H1N1. We'll inform 937, we'll fill up the COVID-19 form by the crisis management team, and we'll get HACCP number and transfer sample by express services. If patient is coming positive COVID-19, treat as per COVID-19 criteria. If negative, then in the intensive care unit, intensivist will decide to out of the isolation this patient. Now, this is the pathway of transferring COVID-19 positive patient. If negative came, I discussed with you, if it's coming negative, it will go with the criteria. ICU consultant will see will all of the clinical findings, radiological images, and then he will discontinue his isolation. But if the patient come positive, especially as Dr. Madhi was telling, the cluster has 3 to 4 hospitals where the different phases will end up with different bed capacity. So, for example, nowadays, all the phase is transferring the patient, or all hospital positive COVIDs are going to Imam Abdur Rahman. So once any case positive in King Saud Medical City or in any other cluster hospital, immediate crisis management team will be informed and they will be activated through the hotline. The medical team will write down the report, and if the patient is already in ICU, ICU team will write down the report and will move the patient as early as possible to the designated health facility or designated hospital. If the patient is stable enough without oxygen, we'll go to the designated health facility. If needs ICU or hospital care, he will go to the specific this area. Remember, the crisis in team management nurse will take care of all the documentation and all the screening and testing and tracking all of the people to provide the PPEs along with the their identification as well, that who was with the patient all the time. Now we move towards our last slide, that how we define the duration of isolation and what are the precautional pathway. So there are two types of cases. One is suspected cases and one is confirmed cases. We define what is confirmed case. So confirmed cases, once confirmed, we have to define in two: either a symptomatic patients or asymptomatic patients. If the symptomatic patients have been treated very well, clinically recovered, then we have to do the testing. And once test positive, repeat every 72 hours. If the test result come negative, get another sample of 24 hours apart. If two samples come negative, he can be discharged and can have the instruction to have 14 days home isolation. I don't know that how long this definition and precautional pathway will maintain, but at this moment, this is the policy in the MOH hospitals. If the asymptomatic patient, but confirmed, retesting every 72 hours and get two negative samples 24 hours apart. If two negative samples got, then 14 days home isolation. Now we come to the suspected case. Suspected cases isolation. We tested initially with COVID-19 PCR, came positive. He is evacuated from this group and will go to the confirmed cases, symptomatic or asymptomatic. But if suspected and patient is clinically stable or clinically unstable, clinically unstable will be admitted to the hospital for isolation and for management for next 14 days. And clinically stable, this home isolation or isolation is designated facility will be considered based on assessment by public health team, health inspector, or the command control center. And until the results will available, they will be advised to have 14 days isolation or not. That was my slides. And now we'll move towards the questions. If anybody has questions, thank you very much for listening.
Thank you, Dr. Shukrat. If there is anyone has a question, they can write in the chat room or they can raise the hand.
Yeah, I think we can answer the questions if we are getting any question, and we can answer. So one question came that a health professional gets COVID-19. They recover and have two consecutive negative swabs over a period of 2 weeks. Do they still need 14 days home isolation after two negative swab results according to MH or local guidelines? Yes, up till now needed 14 days home isolation. It is Dr. Naz. So yes, up till now MOH guidelines are saying if it is negative, after the second sample negative, 14 days home isolation is still recommended. Only one swab is enough to free from isolation. Multiple, this is from Dr. Mamuna. So multiple guidelines are there. For example, as an intensivist, when I see my patients in isolation, and if the first sample is negative and patient is clinically fine by radiological images, lab results, and clinical condition, I usually discontinue the isolation. But somewhere the infection control or this one, if you are in doubt, they need to send the second sample. If a patient is critical and tested positive in our hospital, if critical and tested positive, for example, in our hospital means from King Saud Medical City, yes, then our teams and ICU team is ready to serve the patient. And till stabilization, we will not move and we will stabilize him in our hospital. Next question is, what if patient symptomatic and confirmed, but had two negative tests, should have discontinued isolation or wait 14 days? I think almost the same answer I have given. Do we shift him to another hospital? If clinically stable patient, yes, can be transferred to other hospital. It is mandatory to transfer to other hospital. It is a crisis management. So it's crisis management not to expose your healthcare professional while you have the plan according to your phases, as Dr. Madi have told in his presentation. Should primary care physicians be doing COVID-19 swabs in the community? I think Dr. Nadeem, I think they're moving. That's why the Makkah and Medina results are so high. Now the sampling has been tested and tracking has been done in the community as well. Any role of CT chest in the case definition? No. Case definition, there is no role. It can go with the phenotyping and in the management, Dr. Bandar. as far as I know, sensitivity of nasal swab is 63%. Yeah, it's 63 to 70% is sensitivity is there, but still this is the best method where we are getting the results. Which investigation should I do first, PCR or swab? I think swab testing is going on through the priority based investigation.
Dr. Shahzad, there is one question from Dr. Nadeem. He's unmute now, Dr. Nadeem, if you can ask.
Okay. Yes, Dr. Nadeem, welcome.
Dr. Nadeem Sheikh.
Hello, can you hear me?
Yes, you can.
Yes, Dr. Nadeem.
My apologies. Actually, it was the same question about community testing, because today I heard some figures that the huge numbers of increases in the cases diagnosed in Saudi Arabia is because there's a lot more testing being done in asymptomatic people in the community. So my question really related to that was, should we in the community be doing testing privately ourselves as well, not just MOH? Do you think that's appropriate?
Dr. Nadeem, I think up till now, all the testing which is going on, it is going on through the government organizations. So even if it is private based with the, with some payments, still it is linked with the government setup. So I think if any symptoms or by case definition, any clinical presentation with the epidemiological link, we should go with the government channels is much better.
May I add, Dr. Shahzad, there is now the Ministry of Health, they are doing screening for the staff in some hospitals according to the information what they have. Because just 2 days ago, there is one of hospital, Iman Hospital, they did screening for the nursing staff there.
It's true. And even I was doing last week in the isolation area, and because the 3 cases came positive with me, and we were having to move, we have to move them to Imam Abdul Rahman Hospital. Those patients were stable but positive. Then all the staff, even including me, were interviewed, and how the contact was there, it was screened out, and many have been sampled out, and many have been sent for home isolation as well. But again, I will say that this is a crisis management. So crisis management usually goes that how to maintain the health professionals in a duration, in the time duration where we can have the manpower, as well as if there is any exposure can be isolated.
So from our infection control, actually they are tracing these cases, the positive and the contacts. Also the Ministry of Health, they are doing a great job also for the tracing. In addition to that, we have a pathway for the staff if they have a good exposure. According to that, the pathway we have to go through it. Thank you, Dr. Shahzad. Thank you a lot.
I have a comment actually, and I agree with Dr. I think Ali Zahrani, and the question of Dr. Nabil actually. Yes, most of the detected cases yesterday and day before yesterday, which is exceeding thousands due to mass screening, but they are doing it for the community, which is have confirmed cases. They don't know the index or the source. Most of them from the supermarkets, like for example, like this. So they are screening the district which is having the confirmed cases. We don't know the source of the index patient in this area, so they are screening. As well as we are doing in any healthcare facility, once you have any case, you are almost, if they can, gathering in the context of exposed or protected and unprotected, they are doing for them screening. If they cannot, they can do it as a mass screening for all. So I think
Dr. Mahdi, yes, I think I have 1 minute still. Huh? It's 8:58. So you're absolutely right that mass screening has been started, and especially Makkah and Medina. I got the reports, and for the audience as well. Yes, where the district they have found more than 10 or 12 cases, they have a plan to do screening of that district.
Yes.
Thank you all. Over to Dr. Mahdi.
Thank you so much, Dr. Shahzad. There is many questions. Actually, I think Dr. Tasmiya, she's the next speaker. She's a coordinator of the infection control in ICU. She's ICU assistant consultant, and she will present the infection control principles in ICU, donning and doffing, and how to deal with such case. Thank you, Dr. Shahzad, so much.
Thank you, Dr. Mahdi.
Okay. Dr. Tasmia, already?
Assalamu alaikum.
Alaikum assalam. How are you, Dr. Tasmia?
Yes, I'm good. Alhamdulillah, Dr. Mahdi.
Can you share your screen?
Yes, I'm scared.
And make it full screen because it was not full screen, please.
Okay. Is it okay now? Is it shown?
Yes, it's clear, Doctor. But make it screen show and you can start.
Okay. Assalamu alaikum, everyone. I'm Dr. Tasmia from ICU. And today I would be talking about the infection control precautions or the measures that you need to take. So as with every outbreak that we face, this one that we are now facing is different from all the outbreaks that we had. And as you know, it's been declared a pandemic, which means that it's been taking place in almost or affecting all the geographical regions in the world. So it's our duty and responsibility to take all the infection control measures to safeguard ourselves as well as our family members. So to go on, hand washing is the single most and important and the very easy method for reducing the transmission of pathogens. I must emphasize the importance of hand hygiene here because as you know, for anything, hand wash has a very, it's very important. So this needs to be done during the 5 moments. And the 5 moments are before you touch a patient.
Tasmia, if you never mind, make a slide show.
Okay, doctor.
Full screen. Thank you so much.
Yes. So you need to do it before any clean or aseptic procedure, after any fluid or body fluid exposure, after touching a patient, and after you touch the patient's surroundings. Now, when exactly do you do hand rub and when you do hand washing is important. If you have your hands soiled with blood or any kind of respiratory secretions, it is important for you to do hand hygiene, which is hand wash. Otherwise, you could, it's hand rub is good enough, where the time duration again varies. In case of hand rub, you need to do it for a minimum of 20 to 30 seconds, and you need to follow the WHO sequence of hand wash or hand rub, which involves taking an adequate amount of the hand rub or the alcohol disinfectant on your palm. The first step includes rubbing palm to palm, and then you have palm to dorsum, likewise on the other hand. And then you have the next step where you have with the fingers interlaced. Then you rub your back of the fingers to the palm. Then you clasp the thumb and try to rotate it and do it with friction. Following that, you have the pulp of the fingers, which you need to rub to and fro, that is forward and backward motion. And then finally, you have the wrist. Okay, so these are the steps. It is the WHO sequence of doing the hand hygiene. And you need to spend at least 40 to 60 seconds when you actually do your hand hygiene. Now, another important thing is how you wear your PPE and how you take off your PPE. So this is a standard sequence or the CDC sequence that we follow, and is the recommended one that we follow. Different institutions have different protocols of donning and doffing. However, this is the one that we stick to and highly recommended. So before you put on your personal protective equipment, again, it is very important that you do your hand hygiene. You need to do your hand hygiene either with alcohol rub or you need to wash your hands. The first step is you need to wear on your gown next. So once you wear on your gown, make sure that you secure the ties of the nape of the neck as well as around the waist. Okay, make sure that the entire gown, the purpose of the gown is to cover you completely, not to contaminate your clothing and to avoid any splashes that could be generated by respiratory droplets and so on. So it is very important for you to make sure that your clothing is protected. The second thing that you wear is your mask. again, make sure if it is a surgical mask, okay, the darker side of the surgical mask is the outer part, and the other side, which is the whiter one, is the inner aspect, because many of times it is confusing for anyone. So it is very important for you to know which is the outer side and which is the inner side. Then you have the metal aspect, which is the nose string. Okay, that's the upper part of it. So make sure you tie one of the strings above your ear and the other one below, and make sure you mold your nose piece to make sure that there is no air leak or no space between the mask and your face. Now, the third thing that you wear is goggles or face shields. Some are comfortable wearing goggles, some are comfortable with face shield. It depends on your comfort, whatever you would like to use. And you need to then put on your goggles, which is the third part, and then lastly the gloves. Okay, so let me make this point that we have Ebola suits available for use, especially when taking care of the COVID suspected or positive patients. And we also have surgical gowns. So surgical gowns are mainly used because of the permeability, or because of the quality of the yellow gown, which is very, very thin. And because it is very permeable, we encourage you to make use of the surgical gowns, which are more thicker and more protective than the yellow ones. Now, how you remove your personal protective equipment, again, is also very important. As I told you, the most contaminated part once you deal with a patient is your gloves. So it is very, very important for you to remove your gloves first. Make sure that you grasp the inside or the inner aspect of your glove and remove both in toto. Following this, you will definitely have your hands contaminated. So you need to do your hand hygiene and then move on to the next step. Okay. So remember that all the PPEs need to be removed inside the isolation room, whereas you have only the mask, which is the N95 mask, which needs to be removed outside the isolation room. Okay. The second is, of course, the goggles or the face shield. Make sure you just go close to the medical waste container. You try to bend down a little if you need to, and then try to remove it gently. Following any of these steps, when you think you have contaminated any of your hands or any parts of your body, you need to do your hand rub. And third is, of course, the gown. When you're removing the gown, do not be very, very gentle, because the outer surface of your gown is the contaminated part of it. So it is very important to gently remove the ties which you have secured at the nape of the neck. Try to make it inside out, okay, so that the contaminated aspect of the gown is actually the inner part or inside, and you have the outer aspect, the inner aspect, which comes out. So, and then you roll it into a bundle and you put it into the medical waste container. Here, when it comes to disposal of your PPE or any waste that is generated, or infectious waste that is generated within the isolation room, remember that you need to put it into the infectious waste container, which is the yellow container placed inside the patient's room. Now, once you're done with this inside the patient's room, do your hand hygiene, then you come out. Now you're still wearing, at this point, you're still wearing your N95 mask. So when you come out of the isolation room, you need to take off your N95 mask. When you're taking off the N95 mask, make sure you never touch the front surface of the mask again, because it is already contaminated. You need to grasp the lower tie first, followed by the upper one, and then remove it and put it into the nearest receptacle which is present outside the room. So this is the proper sequence of removing your personal protective equipment. Now, as a healthcare provider, it is very, very important for you to get your N95 fit tests. So we have certain stations within the ICU as well as outside who perform fit tests for the healthcare workers. You can just go or visit them and you can have your N95 fit test done, as well as a card provided which says that you are fit tested for this particular size of the mask. So when you're actually caring for the patients who are suspected COVID, you need to insist on the same size which you have been tested for. Okay. The other picture here shows the Ebola suit, which I was talking about. Okay, these are Ebola suits, and this personnel, who is a EMS personnel, is actually wearing a PAPR, which is the full form of it is powered air purified respirator. Now, many people ask, when exactly do you need a powered air purified respirator? So if you have failed your N95 fit test with almost all the sizes that are available, or if you are bearded, if you have a beard that makes the N95 fit test next to impossible or doesn't fit you, in such cases, you need to go on to use a powered air purified respirator. Now, there are simple things which could be kept in mind, especially when you're dealing with such patients. Always keep your hands away from your face. Never touch your eyes, your nose, or the mouth with unwashed hands. Cough etiquette is something which you need to know. How you cough is very, very important. You need to cover your mouth and nose with a tissue, especially when you cough or sneeze. You need to dispose the tissue into a nearest receptacle after you directly use it. Remember, you may not be carrying a tissue all the time. So in such circumstances, you need to cough onto your sleeve. Okay. And once you're done with this, you need to do your hand hygiene with an alcohol-based sanitizer, especially if you have contacted the respiratory secretions. Now, we come across a lot of cases suspected of COVID, and it is very important for us to report such cases. So what we do is there is a particular hotline, the MOH hotline, which is 937. We notify them that we have a suspected case. There are health inspectors who are on duty in the hospital and they are on shifts. So we need to contact them. They would register this case in the Health Electronic Surveillance Network. And once this patient is registered, you need to send a sample for the screening. Now, the kind of sample that you need to send is, if a patient is spontaneously breathing, you need to send a nasopharyngeal swab. And if you have a patient who is intubated, you need to send a deep endotracheal aspirate. Now, it is very important that the person who's collecting the sample is well trained in the technique. Also, please note that the procedure itself is aerosol generating, so you need to do it in a negative pressure room. Okay, what you mean by negative pressure room is the door of the room needs to be closed all the time. The negative pressure inside, okay, it has to be a negative pressure room whereby there are at least a minimum of 10 to 12 air exchanges that are taking place inside the room. So also you need to wear on all your PPE, especially your N95 mask, your face protection, everything, including your gown, gloves, etc. when you're doing this, because it is aerosol generating. Now, in certain institutions, of course, where there is no facility for negative pressure rooms, they do go about doing this procedure in a single room with HEPA filters. However, in case of facilities where you do have negative pressure rooms, make use of these negative pressure rooms in order to do the swabbing. Now, once we finish with hand hygiene and how you put on your personal protective equipment, it is very important that if you have respiratory symptoms, it is important that you take preventive actions. So what you need to do is wear on a mask, okay, and then try to keep yourself away from other, like social distancing is very, very important, because you may try to spread the cough droplets or the respiratory infection to others. So it's very important, if you are sick or if you have this, to put on a face mask. That's the first step. Of course, as you go to the ER, you have a respiratory triage that is followed. You are screened for your signs and symptoms. You have a certain criteria, a checklist which scores you for a particular score. And if the score is more than 4, you are screened for, or you are directed towards the respiratory triage and instructed for isolation. Now, again, it is very important what kind of precautions you follow is, of course, standard, contact, and airborne precautions. Okay. What do you mean by standard? Is standard precautions are general precautions which we generally follow for all kinds of infectious conditions. Contact is, again, it is very important for you to wear your gown and your gloves. And airborne, as I already stated, you need to put on your N95 mask, you need to put on your face shield, your all your personal protective equipment, and make sure that the room is negative pressure room. Now, where do you place these patients? Once a patient is suspected of COVID, you need to place critically ill patients. It is generally recommended that you have critically ill patients be placed in negative pressure rooms. And you have the less critical or the non-critical cases, they could be placed in single rooms with HEPA filters. Now, the HEPA filter should be located exactly at the head end of the patient. Of course, there is a lot of, we have restricted all the visitors from visiting the patients, and a logbook is always maintained, especially before any patient or any healthcare worker enters this particular room of suspected case, because this makes the contact tracing easier. For example, if you have a patient who is already positive, you could trace who had been in contact with the patient, and the contact tracing would be easier in this case. Now, what are the aerosol generating procedures? Again, we have tracheal intubation, we have non-invasive ventilation, tracheostomies, cardiopulmonary resuscitation, manual ventilation before you intubate, bronchoscopies. All these are aerosol generating procedures. Now, bronchoscopy is generally not recommended in such patients again. And another important thing is nebulization. So nebulization is also not recommended. If you do have to use, you can use a metered dose inhaler. Now, again, you need to take all your precautions as you take for any airborne isolation precaution. Make sure that you are fit tested. Make sure you have the particular size of the N95 mask available. Once you have the particular size available, you need to do a seal check. Now, how you perform a seal check is you put on your N95 mask, you try to mold your nose piece, okay, the nose metal end which is present at the nose piece, and you take a deep breath and exhale. Now, when you exhale, you need to feel some pressure inside the mask, okay? And there must be no air escaping along the side of the mask, which ensures a very tight seal. Also, you need to put on your eye protection. Make sure you put on the surgical gown, as I already stated, when you're doing this kind of a procedure. And of course, the procedure to be done in a negative pressure room, as I stated. Now, it is very important that you limit movement of such patients or transport of such patients out of the room, and do it only when it is really necessary. Use designated portable X-ray equipment and important diagnostic equipments for such patients. If transport is really required, you need to use routes which minimize the exposure to other healthcare staff. Ensure that when you transport such patients, you need to put on all your PPE, including your face protection, your N95 mask, and so on. And you also need to notify the receiving area about the patient's arrival so that necessary precautions can be taken, and routine cleaning and disinfection of the wheelchair or the stretcher which has been used should also be carried about. Now, transporting such patients to interfacility transport, as I already stated, like you're transferring a particular patient on an emergency basis for any diagnostic procedure. In such cases, again, you need to notify the receiving area, put on a surgical mask to contain the cough or the secretions in case the patient is spontaneously breathing. You try to make use of routes that minimize exposure to the staff. Healthcare workers transporting should wear all your PPE. Perform hand hygiene before you put on and after you remove your PPE. Now, if you have a patient, N95 mask again should be used whenever you are transporting a patient to another facility or when you're inside the ambulance, okay, or any kind of aerosol generating procedure is expected to happen during the transport. Now, also a dedicated elevator is supposed to be used for patients suspected COVID, okay? And you shouldn't use the elevator where you have food services and other things that are transported. And once you receive or once you transport this to the receiving area, you need to change on or remove your PPE and do your hand hygiene. Now, we also, as you all know, we also transfer patients to other hospital, and Imam bin Abdul Rahman bin Faisal being our center, we do transport a lot of patients that turn out to be positive in our unit. So make sure that when you are transferring, again, it is very important that you transfer such patients in negative pressure ambulances. Okay. Another important thing is we have capsules, transport capsules, which are available. These are negative pressure and safer for transport of such patients. I don't have a picture here exactly, but it's just like a transparent capsule which accommodates the patient. It has negative pressure inside and would therefore protect the other healthcare staff who are transporting such patients. Now, once you give endorsement to the receiving hospital, you will change on your PPE, you will remove all your PPE there, and then you will put on your new PPE before arrival to your designated hospital. And once you reach the EMS entrance door, you would remove your PPE. Also, it is very important to ensure that the ambulance is cleaned, okay, with whatever approved disinfectant that is provided by the MOH. And we also need to ensure that the terminal cleaning is carried about, especially of the ambulance and other surfaces which have been contacted with the patient. So all the cleaning and all the cleaning of the capsule, everything needs to be done once the patient is transferred. Now, it is also very important that you dedicate medical equipments on such patients, like, for example, stethoscopes, blood pressure cuffs, thermometers. All these need to be designated for such patients only. Make sure you have only minimum supplies available inside the room so that you don't contaminate everything which is inside the room. The other thing is, of course, the non-medicated, by a specifically approved disinfectant and so on. Also make sure that you clean your personal belongings like mobile phones, your stethoscopes, and so on with the alcohol wipes that are available. Make sure you disinfect them on a regular basis, especially when you are moving from one patient to another. And special attention is also given, especially to the frequently contacted surfaces like the bedside rails, the bedside tables, the ventilators, the monitors, and so on. Now, there are certain things which have been addressed to the public, that which certain do's and don'ts which are recommended. And here I would say that they generally recommend that you wash your hands with soap and water after touching animals and animal products. Never to touch the eyes, nose, and mouth, especially with your bare hands. Not to touch any rotten animal products. Okay. Not touching animal waste or fluids that are present in the market. Avoid consumption of undercooked or raw meat or animal products. And as you all know, patients with higher comorbidities are those who are elderly and who are immunocompromised. And these kind of patients succumb to this particular virus earlier. Now, what happens when a healthcare worker is exposed to a positive case of a COVID? Now, all the healthcare workers should report their exposure to their direct supervisor and to the infection control team. Now, many a times we have such patients who are already in isolation rooms. In such instances, the healthcare worker would have taken all his precautions, okay, would have worn his PPE and everything, and would have gone into the room. But in certain instances or certain circumstances, there would be no rooms available or no negative pressure rooms available, and you may have this patient in an open area sometimes, and you would have contacted this patient not knowing that this patient was suspected. So this kind of a contact or exposure could also happen. And in such cases, you need to report. The infection control would kind of do a risk assessment, okay, based on what kind of exposure you had, whether you were protected, whether you were not protected, and based on the presence or absence of symptoms. Now, the post exposure management protocol, of course, includes you being stopped from duty and getting a swab done, which is also instructed by the infection control department. And the decision to permit a healthcare worker or to resume his duties is also the decision of the infection control team, and it is individualized. Okay. Now, you also need to observe, if you are asymptomatic, you need to observe yourself for a period of 2 to 14 days, which is said to be the incubation period of the coronavirus. And here you need to observe yourself for any signs and symptoms and report if you do develop any signs and symptoms. Now, the home care patients exposed to COVID, again, this was what you also have patients who may be in the same vicinity with the suspected or the positive case. Okay, in such cases, it is very important that you screen such patients. Testing of the nasopharyngeal swab or a deep endotracheal aspirate may be required. And these patients are also followed for signs and symptoms for a period of 14 days. And in those period of time, if they do develop any symptoms, they need to be screened again. Also, patients who are discharged, who are stable and who are discharged, they must be followed up regularly for any signs and symptoms. Now, what exactly do you do in case of home isolation? Again, when you are home isolated, you need to take care of yourself, you need to take care of your family, make sure that you do your hand hygiene, especially after coughing and sneezing, especially after you prepare your food, before eating, after using a toilet, before and after caring for any other person, and whenever your hands are dirty. You also need to follow the respiratory hygiene and the cough etiquette. You don't have to share your utensils, your dishes, the towels, and so on with your other members staying with you. Try to maintain social distancing. This is very, very important. And monitor your health as well as the health of your family members. So these are the things you are expected to do, especially when you are in home isolation. So with this, I finished my talk on the infection control precautions.
Thank you, Dr. Tasmia. I have a question. There is a question regarding the form when the patient came to the ER. There is two options. There is screening or confirmatory test. So which one they select and what does it mean?
Sorry, Dr. Kohel, can you just repeat your question, please?
Actually, there is a question. They said any patient came to the isolation, there is a form. In the form, there is two options. Either the patient for test for screening or for confirmatory. So they are asking what's the difference?
Yeah, what I have seen is, of course, in many places, the test that they do is the diagnostic test first, and then you have, which is the screening, and then you have the confirmatory test. So many of our results in the hospital that we get also have the same. They have a screening test and they have a confirmatory test. Okay, this is particularly because the reliability of these tests was really not very valid. I mean, the validity of the test was really doubted initially. And as you see, when there was when a lot of cases started to emerge, they started to do surveillance testing. So when they did the surveillance testing, they had kits and not all of them were reliable. So some of them were diagnostic tests only. They could just tell you that these are positive. But however, they needed confirmation. And these diagnostic tests, the turnaround time is very, very almost around 45 minutes. So if you really need to do a very quick test, you can do it, which gives you a result within 45 minutes. However, this needs to be confirmed and this takes a longer time. It would take days to confirm it. So here what we do, or the tests that we normally do in the MOH are for the screening test and also the confirmatory test. Hope I answered your question.
Yeah, okay. There is another question. There is no goggles in the KSMC, only face shield.
Okay. We have requested for the goggles. We had very, very limited numbers, but yes, I do agree with you that the goggles are very limited. However, even the face shields that we have don't cover you adequately, especially the sides. So we have requested, and inshallah, we are awaiting them. And once we have the supplies, we will definitely notify you. We are expecting to receive the supplies of the goggles.
The other question, when should I wear Ebola suit?
Yeah. Ebola suit is especially when you are dealing or taking care of these confirmed cases of COVID. And also especially when you need to transfer such patients to another facility, or in case of inter-facility transfer, you can use these Ebola suits. They are complete, they cover you completely. unlike the surgical gowns or the other gowns that we normally have. They would have a cap, they have a hood, they have shoe covers, and they would keep you covered completely with these suits. Any other question?
Yeah, there is another two questions. Last two questions we will take because we have to move to the next session. Is it recommended to wear a double mask? The other question, what do you do for screening? Which test or lab is the screening test?
Okay. Is it recommended to wear double mask? No, it doesn't. It does not protect you. Double protect you completely. What do you mean by double mask? Wearing a surgical mask and N95 onto tight fit. So it's very, very important. Remember that you just wear your N95 mask, especially the size of the mask that has fitted you, and emphasize on that particular mask itself. So it's always better to get yourself tested for at least 2 sizes, so that if one is not available, you can go for the other one. But never wear a surgical mask, and on top of that, putting on an N95 is not doesn't protect you in any way, because you need to have a tight seal. Okay, you need to have some tight seal between your face and the mask. The second thing is for females who wear a veil. Again, it is very important that you put on your mask under the veil, not outside. Okay, so this is another important thing that you need to note. So put on your surgical mask if you're wearing, put it under your veil, and also make sure that you don't have anything else like double mask or wearing two masks. So the mask that you wear has to be a triple layer mask. This is very important also. The surgical mask that you wear has to be a triple layer one, which can protect you from the respiratory droplets. The other thing is, of course, the screening. The screening test that we normally do here, of course, as you see, is the nasopharyngeal swab. And we have the deep endotracheal aspirate. As I already told you, you need to do it by a trained personnel who is trained in the technique, because as already stated, you can have false negatives. Okay, you can have 30% of false negatives. So it is better for a person who is trained in the technique to be doing the nasopharyngeal swab. And of course, we have some of our nurses who are trained and they go about doing this test.
There's another question. What about wearing double pair gloves? And the other question, any rule for yellow gown?
Yes. So again, as I told you, the double gloving is recommended in some of the institutions. You can go about wearing a double gloves. It's definitely safe and recommended practice in many of the institutions. There's no harm in this. And the other question, of course, was, sorry?
Any rule for yellow gown?
Yeah, yellow gown, as you can see, is really inferior in quality. Okay, it is not. Whatever you have or whatever gown you have must be impermeable. It must be fluid resist. It must be fluid proof. I mean, when you come in contact with something fallen on your gown, it should not penetrate your gown and get onto your clothing. So it's very, very important that it is leak proof and resistant to any kind of fluid. So if these qualities are not met, it is definitely useless. So the yellow gown that we have is really inferior in quality. It is really, really thin, and I wouldn't recommend you to wear this, especially when dealing with such patients of COVID. This is why we recommend using your surgical gowns, which are far more thicker and or of better quality, to be used, especially when you are taking care of such patients. Okay. The ideal would be to use Ebola suits, but if you don't have them, you can go about wearing your surgical gowns for caring these patients.
So this is the surgical gown for the confirmatory cases or just any patient in isolation?
This is for the suspected or the confirmed cases of COVID.
Okay, but there is one question. I note some physicians, they are wearing a surgical mask and above that N95.
Yeah, this is what I'm trying to say.
How is the because I think it will make not fit. Even it's fit, it will make it not fit.
Yes, definitely. It wouldn't fit. I mean, the mask should snugly fit on your face. So this is what I'm trying to say. If you put on a surgical mask, it wouldn't fit you. The N95 mask that you are fitted for wouldn't fit on your fit on your face snugly. I mean, there will be some space or some air leak that can happen between the mask and the N95. So it is very important that if you're wearing N95, just put on your N95. And if you're wearing your surgical mask, just wear your surgical mask. I mean, don't try wearing two masks and so on.
Thank you so much, Dr. Tasmi. I think the time for Prof. Madi.
Thank you so much, Dr. Madi, and thank you, Dr. Kohel.
Thank you so much, Dr. Tasmiya. Thank you, Dr. Ahmed. Actually, before I'd like, I think I unmute Dr. Ali Zahrani. Ali Zahrani from ER. Dr. Ali, how are you?
Hi, Doctor. Alhamdulillah. How are you?
كيف حالك? How are you?
Alhamdulillah. How are you, Dr. Ahmed?
Thank you so much. Actually, I think you
Thank
have some notes you want to highlight for all of some rules in ER, right?
Yeah. Regarding the movement and transferring through the ER areas, we have two areas in ER. We have dirty area and clean area. So I saw a lot of physicians, they are roaming like from the dirty to clean to the clean to the dirty. We have to minimize that as much as we can. So this is what I want to emphasize.
Yes. Okay.
Thank you, Dr. Ahmed.
So actually, this is for all actually, and I think now you have permission card for people, cards for people going to the ER. Not everyone permitted to go to ER, right?
Yes, we have this red one.
Yes. So, yeah, this is actually recommended. Not everyone going to the ICU or ER unless they have something to do there, because limiting personnel to exposed to move in the very high area of infection. It is actually not preferable at all. Thank you, Dr. Ali, so much.
Thank you, Dr. Ahmed. Thank you.
Thank you. So now we'll move actually, thank you all, to the, I just will go to the quick guide for the, let us say the outlines or overall of the COVID-19 critical care patients. I will not go to the in details for each one because actually later on we will handle each item of those guidelines separately alone in one lecture, right? So just I will highlight on, let us say the outline for the critical care patient in COVID-19. COVID-19 patient coming usually with respiratory distress, acute respiratory failure, and mainly hypoxemic respiratory failure. This is at the beginning, you have these presentations, and this is caused, of course, as definition done by Dr. Shahzad, the coronavirus 2, which is SARS-CoV-2. So the patient usually presenting with the acute respiratory failure. I have my insight, my actual opinion about we have two major domains for the COVID-19 patients, especially COVID-19. If we talk about, for example, MERS or SARS, it is different, totally different. For COVID-19 patients, the two domains, in my opinion, is safety and the clinical management. Those actually, both of them are very, very important. So I want to highlight on your opinion, which is more dominant? It is safety, to know how to protect yourself, or to know how to manage the patient with COVID-19, or both of them. I think if we can have polls here. Do we have? No problem. If we don't have, we can just go through the chat room. So safety. No problem. خلاص يا أحمد. خلاص done now. Okay. Now the polls you have, you can just voting now. Nobody like any clinical management. So actually, next course we will be only just how to protect yourself. 0% clinical management. Still, we not reach to the 75% of the participants. Please. Okay, the same number. So I think we have almost maybe 15 candidates. They just opened the device and they are leaving. So anyhow, majority of you, 64% going with the both. I'm agree with both, but I just want to highlight in this to protect yourself. The lecture done by Dr. Tasmia, very essential in the management. Even it take only one lecture in all our course, but you can find in every clinical management lecture the main difference for the guidelines for the COVID-19 patients from ARDS, the safety. For example, we have a clinical management for septic shock for sepsis patient, or for CPR, or clinical management for ARDS, or clinical management for intubation. All algorithms have the same. But what's the difference between COVID-19 and the standard? It is the safety. For example, when we talk about any procedure, they are highlighting on the safety. Even the SLS guideline of American Heart Association, of the ALS of the UK, they also highlight on the safety. So safety is something very essential in the COVID-19, apart from even MERS or from the SARS. The patient usually admitted to the ICU due to hypoxemic respiratory failure, which is the most common admission cause for ICU. Usually coming after 10 days of the beginning of symptoms, coming to the ICU. It can be presented actually with also shock stage or other atypical presentation, as Dr. Shahzad mentioned. The poor prognostic indicators for COVID-19. This is very important, and Dr. Shahzad highlight actually most of the worldwide guidelines, they are highlighting on three main categories for the assessing the COVID-19 risk factor or prognostication indicators. Epidemiological category, which is mainly related to the age, and all of us know that Italian mortality rate or case fatality rate, it is very high because related to the high age group of those Italian people. As well as many comorbidities also, it can have effect keeping your patient at the risk factor. Vital signs, how your patient presented, severe tachypnea, severe tachycardia, desetting, those actually the vital signs keeping your patient as COVID-19 as high risk. Or something very essential, specific for COVID-19, which is has its pathophysiological explanation for that, which is actually D-dimer more than D-dimer more than 1,000, CPK twice upper limit of the normal, C-reactive protein, LDH, elevated troponin, and lymphopenia, as well as ferritin. Right? They are now even in many literature, they have some sort of COVID prognostication score. They make some score from those labs, actually, like D-dimer and C-reactive protein and lymphocytic count. So these are the three main labs. So we need to do it early and we need to do it late, actually, to check how is the severity of your patient. As you can see it here for this study from the CDC, we can find the mortality COVID-19 is highest among persons with underlying medical condition. We have most of the patient cardiovascular disease, diabetes, and chronic respiratory disease and the cancer. This is a study from China. And this is very nice slide. If you can look at who is patient need admission to the ICU. If you look to this green color, those non-hospitalized confirmed COVID patients, the percentage of non-hospitalized. If you look to the yellow color, those hospitalized but not admitted to the ICU, and the blue color, those patients admitted to the ICU. Fortunately, the blue color for most of comorbidities not admitted to the ICU. If you're looking to the highest, you can find that the biggest percentage will have one or two more comorbidities over the 2,600 patients. It will come after that diabetes, DM, and the highest, which is 26% patient with chronic renal disease admitted to the ICU, but fortunately only 200 patients they had chronic kidney disease and have COVID-19. The highest is diabetes. You can see it here, actually 700 patients, and the others are two double comorbidity, also one from the highest risk factor for admission to the ICU. So comorbidity for admissions, mainly diabetes and mixed, either diabetes plus cardiovascular or diabetes with chronic kidney disease. I cannot say we have two peaks for age group for the patient can be infected. The first one is 20 to 44. The second one is 64 until 84. This blue color column, those the patient got infected with COVID-19, this United States, and 4,000 patients from the United States. You can see the fraction of the total cases here reaching 30% with the patient in young age, and all the age reaching also around 25 to 26%. But if you don't look to this yellow color graph, this is the case fatality rate. So the patient died over the patient confirmed. And you can see, fortunately, the young patient, they don't have highest mortality. But if you go to the elder people, you can reach to the 20% above 80 years old. So the one from the most common isolation recommendation to isolate geriatric patient because of the fatality very high for the patient with old age. If I did ask you, what did you expect the main cause of death of COVID-19? Is it cardiac failure or respiratory failure or concomitant respiratory and heart failure? You can vote. Yes. So we have most of you respiratory failure, 55%, and 33% is concomitant. This is actually the standard. If you look to the percentage, you can find here around 53% patient admitted due to died because of respiratory failure, 33 post and the cardiac failure. Both of them. Mortality correlate with the availability of the medical resource. One from the most important thing I'm always saying in my lectures, the mortality rate, it's different between nations based on compliance with the infection control principles and the national rules, as well as the resources of the medical resources. This is, for my opinion, the most two important point, make difference between the mortality or fatality rate between nations, between different countries. So respiratory failure, the most important. I will go through briefly through, let us say, algorithm to define the stage or phases of COVID-19. You can find many phases for many institutions like Birmingham, like Mass, like UK. So all of them, Malaysia, and everything, UK, China, but most of them actually having the same principles. They classified the patient of COVID-19 into he's coming early, prodromal incubation period, the virus is there, PCR is positive, but the patient is symptomatic. After that, it starts to have some symptoms, but no evidence of pneumonia. So the others, this is the viral effect. The first stage is the viral load effect, but the later stage is the host response. So the host response, pneumonia, this is the third phase, which can be either pneumonia, plain pneumonia without severe pneumonia, without hypoxemia, or pneumonia with hypoxemia. Many of the phases in the other algorithm, they make pneumonia only one stage. The last one, which is critically ill patient coming usually with multi-organ failure and ERDs. If you look to this stage or these phases, it can be explained, even pathophysiology passing through this stage, even medications passing through this stage. So this stage is very essential to know where you are and where is your patient and how to deal with it. So if we go to the severity, this study over 1,000 patient hospitalized patients in China, and 50% of them admitted to the ICU. As you can see it here, the red color, only 5% of those patients admitted to the ICU, majority of them in the mild case, mild to moderate case, in the early phases. 13% of severe cases, which is pneumonia without hypoxemia, right? But 5% of those patients, over 1,000 patients in China, they are admitted to the ICU. And unfortunately, mortality rate with the critical illness admission is not low, it is high. Right? Again, we'll go back again to the same phases we have. Patient coming in the incubation period without any clinical signs, he will start to have some sort of fever, cough, sore throat, arthralgia, myalgia, even extrapulmonary manifestations in the prodromal stage. In pneumonia phase, he have fever, persistent and increased CRP and decreased ALC, as well as chest X-ray, some sort of different infiltration by chest X-ray. Even the chest X-ray, the CTs have, it can be in these stages. It can be classified according to these stages. You can find the early, just peripheral patches. Later on, you can find diffuse infiltration in the chest. Patient with pneumonia, with severe pneumonia, he can have the symptoms plus it will be hypoxemic. It will be hypoxemic with shortness of breath, usually coming late with the can reach the very low saturation, oxygen saturation, reaching to 50% in this stage. Of course, if the host response of the patient is exaggerated and increasing as many mediators and interleukin released, you can find the patient's multi-organ failure. He will come to the shock, ARDS, or multi-organ failure in the immunological phase of the last phase. So this is the clinical status. If you go to the signs and symptoms, this is the 7 studies done in the US, China, Singapore, and US. 7 studies. You can find most of the 7 studies patient coming with fever, reaching to most of the patient 100% until 50% coming with fever. After that, cough, later on dyspnea. So 7 different studies in different areas, most of them coming to the fever, then cough, then dyspnea, shortness of breath. If I did ask you, one from the prognostic lab investigation, or can say severity index for the lab investigation, is lymphopenia, decreasing leukocytic count. But lymphopenia is common in all patients, but doesn't correlate with mortality. Yes, we have lymphopenia, but does this lymphopenia correlate with mortality? Yes or no? True or false? The question, does lymphopenia correlate with mortality? Doesn't correlate? True or false? Less than 0.8 agree? The number? So 56% agree and 44% false. It is false. It does correlate with the mortality, and I will come through it now. Before I will go with the leukocytosis, especially neutrophils. Look to those study in the China from 138 patients, and most of the patients in this figure. This is the leukocytic count, total leukocytic count, and this is the neutrophilic counts. The people here, the yellow color is non-survivors, and the blue color is survivor patients, as well as in the neutrophilic count. As you can see, most of the patients coming, this is the normal range, the black color, the back line. So most of them coming early with normal lymphocytic count, normal leukocytic count, as well as normal neutrophilic counts, but the non-survivor showing leukocytosis with the timing. As you can see it here, after 9 days, we can find increasing in the leukocytic count, mainly neutrophils, the blue color, the yellow color. So non-survivor showing leukocytosis from the 7 to 9 days, as well as also neutrophil counts will be high from 7 to 9 days. But lymphocytic count going down, less than 0.8, as you have mentioned, the doctor said, really. But you can see it here actually, the blue color, which is survivor patient, and the yellow color, which is non-survivor, significantly lower. So what does it mean? It means lymphopenia, it's common, but maybe lower in non-survivor patient. So lymphopenia is correlated with the lower in non-survivor patient. So it is one from that. And most of the severity score of COVID now, the adding lymphocytic count 0.8 in the severity index score. D-dimer, another one. D-dimer is a strong predictor of hospital mortality when compared with other markers of severe COVID-19. Is true or false? Again, we can vote. D-dimer, strong predictor. So once we have a D-dimer is high, more patients will die. It is true or false? You have polls, or we can just go through chat to start to have. Yes, we have. So just 5 seconds more to reach the 50. Yes, so we have almost 84 of you coming with the true. I agree. D-dimer one from the very important predictor of mortality. Look to this study. Look to this one, right? This is showing the D-dimer on the red color for non-survivors and blue color of survivor patient. This is the D-dimer. D-dimer in the day 4 start to increase from day 7 to 1.5, 2.6, up to even 42, right? This one, microgram per ml, very high D-dimer, right? In comparison to the patient who didn't die. So the dead patient shows very high very high D-dimer and significantly high. If you look to the table here, you can find either univariable odds ratio or multivariable even odds ratio. It's found very high. So if you look at actually here, you'll find it 18.4, right? Significantly difference between survivor and non-survivor. And the lecture of the pathophysiology, Dr. Waqqas will touch this, why it is high, and this is the microthrombotics, and many reasons for that. So D-dimer, one from the very essential predictor of mortality of the patient with COVID-19. Again, go back to our graphs. If we go to the pathophysiology has a special lecture for pathophysiology, and there is, of course, as all of you know, there is many pathophysiological theories coming to the last 3 weeks, different from the early, not ARDS, not pneumonia, microthrombi, or different thrombosis. We have many pathophysiological changes, but most of the patients in this stage don't progress to the pneumonia phase. Nasopharyngeal replication early here, it will start to be actually nasopharyngeal replication and binding to SE2 receptors in the lung and the liver, in the prodromal and the early pneumonia. And the last one, patient coming with cytokine storm. Most patients will die in this phase, of course, with interleukin and thromboxane 2. So the pathophysiology is totally different. I have a question here. Of course, in details, you can find this lecture with Dr. Ahmed Balchi in pneumonia, but this is just a refreshing of the phases of the COVID-19. So, ER doctor with intubating COVID patient confirmed. He did a swab from pharyngeal PCR. It came, sorry, pharyngeal PCR. On the same day, it came negative. After 7 days, the patient developed fever. The doctor developed fever, cough, shortness of breath, and they admitted for pneumonia. And chest X-ray done, and they started hydroxychloroquine, azithromycin, and ceftriaxone. At that stage, after 7 days, nasal swab taken, and for PCR done, and repeated, and became negative. So in this stage, this is now, he did first one, it came positive, second one came negative. After 7 days. So what's your next step now? You can just excuse me for a while, please. What's Ahmed here? So in this stage, if you have a exposure with confirmed case, first sample negative, second sample after 7 days with symptoms negative, this is X-ray highly suspicious. So you will discontinue hydroxychloroquine and continue ceftriaxone and azithromycin. You will deal with this patient as bacterial pneumonia, not viral pneumonia, acquired pneumonia, or you will discontinue hydroxychloroquine as pneumonia and upgrade ceftriaxone to tazocine. You will continue same management and do bronchoalveolar lavage and the PCR. You will continue same management and do tracheal aspirate from the trachea, from ETT. So do you have Paul here? Paul, please. I think we have. Oh, this one. Okay, let us see. Most of you have 3, 4, 3, 4, 3, 3. So I can see most of you from the chat room, they said 3, which is bronchoalveolar lavage. I agree for sensitivity, right? I'm agree for sensitivity. Last 2, last 4, last 3, answer 4, which is right. I'm agree for sensitivity of the bronchoalveolar lavage is more sensitive than the nasopharyngeal swab. If you look at here, you can find bronchoalveolar lavage sensitivity is 93%. But as I had mentioned earlier, there is many procedures you can omit, you can stop, don't do it. Okay, done again. Many procedures actually you can stop it just because of protection of yourself. Just because of protection. So one from them is this: the patient intubated and clinically highly suspicious, X-ray showing diffuse bilateral infiltrations. He has typical presentation of the COVID-19. First sample pharyngeal swab sensitivity is very low. Second sample nasopharyngeal swab sensitivity is still 60 plus, as you have mentioned earlier. Right now, he's intubated, so you can take tracheal aspirate blindly. You need to go with the highly aerosolized procedure, bronchoscope. So again, here is your safety. Even bronchoscope sensitivity is higher, but I cannot deal with this patient as COVID-19 and repeat tracheal aspirate. Don't go with bronchoscope because it's very highly aerosol generating procedure. You are doing suction, you are admitting the patient with bronchoscope, you are opening his way, you cannot secure his closed circuits. So don't proceed for bronchoscope unless highly indicated. Don't go with the for just sample and PCR. This curve, I will not go in details because Dr. Balchi will mention in the pneumonia case, but I want to say here, PCR, the blue color, IgM is a green and red color is IgG. Since we have many false positive for the patient on the PCR, it is early diagnosis, has to be done earlier, IgG, IgM little bit late, but if you have a patient on this table with negative PCR and the positive IgG or IgM, consider it false negative. Don't go with the result of the PCR during that time. So we have false negative for the PCR, you have to consider. So the last phase is management. Management actually, also I'd like to inform you, we are doing now a protocol for COVID-19. Protocol for critical care patients, even ER, they have a protocol also for dealing with the patient for COVID-19. We are touching everything for COVID-19 since admission from ICU until discharge. Right? So the management, usually it will be related to the protocol. And this protocol have to be institutional because no any evidence support any management for the COVID-19. All of them are supported and all of them, the evidence lacking behind. So we are relying on institutional approval for example, MOH approved antivirus, specific antivirus, so we'll go through this one. They involve hydroxychloroquine in certain situations, we go through this one. So at the early stage of the COVID-19 incubation period, what do you need? Just you need to trace all contacts and to isolate your patient and observe him. In the second stage, prodromal stage, just observation, hydroxychloroquine or chloroquine in some center you can go, confirmed cases, you can go through. In pneumonia stage, again, hydroxychloroquine and or quinine with antiviral. Hydroxychloroquine antiviral pneumonia, you can have later on anti-leukin 6 antagonists with immunomodulators, with corticosteroids, with IVIG, with plasmapheresis, with convalescent plasma, many modalities actually. So don't worry about the management for the COVID-19 as regarding pharmacotherapy. We'll have a protocol specific for that. It will be almost released after 2 days from now. But as a general, all pharmacotherapy, not widely supported by evidence, it's all related to some small sample of the studies and related to the new pathophysiology mechanism behind that. So management, either antimicrobial, antiviral, interleukin 6 antagonist, steroids, those actually it is non-specific. So again, I will go very fast through the clinical disease progression. We have mentioned disease progression in the first weeks and evaluation and symptoms and signs. Here, investigations and characteristics, lab investigations, and we have mentioned here, don't blindly trust negative swab if symptoms or pneumonia, symptoms suggesting pneumonia with suggestive X-ray. Many of you mentioned about the CT. CT actually, there is some classification based on CT. CT sensitivity for diagnostic of early diagnosis of the COVID-19 ground glass specific. It can be, but again, we are weighing the risk and benefit from the procedures. If you have the patient clinically without CT chest, don't go with routine CT chest, transferring your patient to another setting, another place, another area with more exposure for many personnel, right? If you have just for diagnosis, no. So weigh the risk benefit from any procedures you are doing. As we did agree, lab investigation, you need to go with the blood gas, CK, lymphopenia, elevated CBR very high, and D-dimer is high, leukocyte count, and LFT mostly double or triple. Radiological investigations, we have to have X-ray, CT, echo, ultrasound, And the webinar we are doing after tomorrow, it will be touching radiological imaging for the patient with COVID-19, specifically by Dr. Salman, and thrombosis by hematologist. The airway management, very, very essential. It will be touched in the ARDS airway from the oxygen flow from the nasal cannula until the rescue therapy, until ECMO, right? So which oxygen, the most important again with the airway management, which is the safest device you can use? What is the least device can generate aerosolization? For example, you cannot go with the face mask, simple face mask with 10 liters. It will have more aerosolizations. So they recommend with secured high fidelity cannula. They recommend non-rebreather mask rather than bagging. Don't bag the patient with COVID-19 unless highly indicated because of, again, aerosolization. So relying on the how to protect yourself, you can manage, you can have another modalities. Ventilation, again, from basic ventilation until advanced ventilation, until droning, until ECMO. So all of this will be touched in the ARDS. Intervention, renal, we have another lecture for that. So I think medication, as I mentioned, steroids, antibiotics, antiviral, and new modalities, whatever is it, convalescent plasma, IVIG, plasmapheresis, each one has its role. I want to say many guidelines worldwide and daily, you can say updated. So for example, this campaign, survival sepsis campaign guidelines released almost 3 weeks back. It's almost old. It is almost now, I can say it's old, not new. But again, I want to emphasize something. The guideline, the very, let us say, respected guidelines, they are not highlighting, they are not specifying, they are not recommending any modalities either for treatment, especially for treatment, or even intervention by the respiratory intervention or respiratory support, because they're lacking the evidence. But what you can find observational study elsewhere. You can find some data about any modalities of the management, any centers, and they are posted as evidence. Still, no evidence. And I want to say that even the most hot drugs, hydroxychloroquine, worldwide, they investigated and until now not in the guidelines, but even all everybody using it. So with some precaution. Again, with pharmacotherapy, we will touch this in details. But I just want to highlight, actually, me and everyone in the country here have to be proud. The first author of the guideline of survival sepsis campaigns, Walid Al-Hazzani, is from military hospital and now working in the McMaster University. He's #1 almost now in the grading system of the all guideline worldwide related to critical care. It's very eminent researcher, actually. So this is main reference for all of the medication. I'd like to thank you for this is the guide, I think, quick guide, and in details, each section will be touched in details. So I have, let us go first for the chat questions. Then if someone have to comment, raise his hand, we can go through. So I'll go to the chat room. Difficult to understand. But safety. Don't worry. I'm saying again, who's difficult to understand the quick guide, every part will be touched in details. And again, every special part, we have a protocol. We have a guideline for that. So don't worry. Don't worry about the clinical management. What my opinion, to have to take care of, to pay attention to your protection, how to protect yourself during this endemic. This is the most important. It doesn't mean you will escape or you will go away from the contamination, but you have to protect yourself and to be. It's very easy. There's many protection procedures you have to take care while you are doing any step for the clinical management. Available offline, yes, it will be daily. You will find a link for recording of all lectures. You can find it in the group. Dr. Ahmed Kuhail will be doing that every day. All the group, every day you will find a link to can follow the lectures offline. Any more questions? Restrict IV fluid? Yes, yes. From ARDS, even restriction of the IV fluid, we have two theories for the fluid management, which is conservative versus liberal fluids, right? As a general, for ARDS patient, restrictive fluid, conservative fluid management is better than liberal fluid management. But if you go, for example, the patient in septic shock due to COVID patients, the standard sepsis guideline, they said you have to go through 30 ml per kg. So you give your patient in first hour almost 2 liters of fluids, crystalloids. But what's recommended now in the COVID-19 specifically? No. We like to give bolus, resuscitation fluids of bolus, give first 250 to 500 ml. Then check the response. Does your patient need more or not? You have any side effect of overload or not? So restriction of the fluids, one from the management of the COVID-19, whatever the phenotype of the ARDS. Especially for us who have airway and ventilation, don't worry about that. I want to say airway, we have a special lecture, of course, it's not enough, but one from the important thing, we dedicated airway team. So airway team or intubation team will be responsible for the intubation of all COVID patients in the hospital, whatever in ER, in the ward, and ICU, to decrease for two reasons. First, the most expert one, to decrease the failure rate. Second one, to decrease the personnel exposure to the any intervention. So what we are trying to do, team for every procedure. So what we have now done, airway, we have team for the airway. Why D-dimer is in the COVID-19? Dr. Waqas, he will mention in details in pathophysiology of microthrombosis. He will mention this one in details. Repeat the poor prognostic factors. It will be posted again. Prognostic factors, we have three categories. The first one, epidemiological categories, including age and comorbidity. Second one, vitally, including heart rate, blood pressure, tachycardia, and saturation. Third one, lab investigation, which is including ferritin, C-reactive protein, LDH, and lymphopenia, and D-dimer, right? So three categories, epidemiology, vital signs, as well as the lab investigations. The best is eupholemia. No, nothing best, by the way, okay? Eupholemia, in certain conditions, you need your patient even dry. And this one based on the stage of the fluid therapy. For example, you are giving your patient fluid therapy in resuscitation. So in the resuscitation phase, he needs to be positive, a little positive, not high positive. But later on, you have to take this fluid out. So I cannot say I want all my patients eupholemia all the time. No, sometimes it has to be positive early if he's losing fluids, if he has valvular electroshock due to mediator or sepsis or any reason for that, but later on you have to keep it negative. And they found that patient in septic shock 2 days negative in ICU over 7 days, he have a good survival rate. Sure, ECMO, there's a rule for ECMO as the last step of rescue therapy. Also, we have criteria for the patient to be connected to ECMO worldwide. Also, guidelines. Everyone, they didn't have a specific guideline for ECMO patient because they cannot assess. And most of the patients have old age with comorbidity, they're not connected to the ECMO. Even now, in our protocol, we restrict the ECMO for 50 years and less. So patient need VTE prophylaxis? Yes, VTE prophylaxis, a big dilemma. Prophylactic therapeutic, the dosing age, also in our protocol, we are mentioning that prophylactic as a standard of care, but some people need some higher dose of prophylaxis, another people so double, maybe BID Crixan, another with D-dimer even. Some of them, they specify the DVT based on the D-dimer number. So for that, we will have a protocol and will be announced, and Dr. Bashir will touch it in details also about the prophylaxis. Our rule to prevent cytokine storm. This is the last one, last step. There is some of the 70 patients in China, they try with him with the removal of the cytokines by artificial blood like Oxyrus or Cytosol. They said clinically biomarker decreasing is really and the vasopressor decreasing, but I cannot say there's guideline for that. right? But cytokine removal by artificially with dialysis, it can be done, and we are planning to do in our patients. Regarding mortality, lymphopenia, or both of them, D dimer is more. Higher D dimer, higher the mortality. High D dimer, yes. Does D dimer? Yes, D dimer, yes. Great. He answered.
There is a question from Dr. Nadim also. He's raising the hand.
Oh, yes, you can give him the.
He's
open the mic, please.
Okay. Yeah. Thank you, Dr. Mahdi, for letting me ask you a question. I wanted to ask you actually about hydroxychloroquine.
Yes.
As you know, it causes a lot of controversy in the medical world about its use.
Yes.
And I note that you have included it in your presentation as something to be used in the prodromal phase, which is obviously different to what is happening in many other parts of the world. So on that note, what I wanted to ask you is this. The Indian Council of Medical Research has advised from a safety point of view that it should be used on a weekly basis as chemoprophylaxis for healthcare workers involved in COVID-19 patients. What's your opinion about that, please?
Yes, I can say, I'm working in Saudi Arabia and I'm originally from Egypt, right? Egypt, they are posted it as a prophylaxis weekly for patients with healthcare worker for hydroxychloroquine. But my opinion, I'm not supporting it. Hydroxychloroquine, even worldwide, using for all patients is confirmed case only, not using for the prophylaxis. The very limited institution using it as a prophylaxis, I'm saying even Egypt, the Ministry of Health, they posted it as a prophylaxis for healthcare workers. Not recommended. The studies behind the hydroxychloroquine, at beginning, only 6 cases, which is showing improving at the beginning of the French study. Later on, even one study published in NEJM showing it doesn't improving the outcome. Another study in China showing also doesn't show a good benefit. But even though, decreasing with hydroxychloroquine, even with the new pathophysiology of porphyrin, it can working. Hydroxychloroquine, again, I don't like to touch the lecture of Dr. Bashir. He will discuss hydroxychloroquine in details, right? But I want to say, based on institutions with low evidence of supporting hydroxychloroquine, all countries using it for confirmed cases. Very less countries or very less institutions using it as a prophylaxis, and are not recommended because of actually its side effects. Thank you so much for all. I think we take longer time. So inshallah, if no more questions tomorrow, we'll just at 8 p.m. inshallah, we'll start another day for the course. Thank you so much. See you tomorrow, Bismillah. Shukran, Ahmed. Shukran. Thank you, Dr. Thank you all.